Hi everyone, welcome or welcome back. In this webinar we're going to look very briefly at the possible routes of transmission for SARS CoV-2. Our knowledge is changing significantly on this topic, and it's changed since the epidemic began in March this year, and it's even changed in the last couple of weeks. The first mode of transmission is contact and droplet transmission, and we've known about this from the start. Respiratory droplets of 5 to 10 micrometers in diameter can be transmitted to another person when you're in close contact, so that's within a metre or two of an infected person who has respiratory symptoms and they're talking or singing or coughing or sneezing. In these circumstances, respiratory droplets that include the virus can reach your mouth, nose or eyes and can result in an infection. But these droplets fall to the ground relatively quickly. Fomite transmission. Those of you with good memories will remember that fomites are inanimate objects where you can pick up recently deposited virions. Viable SARS-CoV-2 virus and/or RNA detected can be found on those surfaces from periods of time ranging from hours to days, depending on the ambient temperature and humidity and the type of surface. This particular infographic, you should note that not all of these data are for SARS-CoV-2. Some of the numbers are for the current COVID-19 causing virus. Some of them are for MERS, the Middle Eastern Respiratory Syndrome virus, and some of them for the first SARS that emerged in 2004, and that just depends on whether or not we have data for the current virus. Airborne transmission. So we just said that respiratory droplets are 5 to 10 micrometers in diameter. Droplets that are less than 5 micrometers in diameter are referred to as aerosols. Airborne transmission is defined as the spread of an infectious agent caused by the dissemination of aerosols that remain infectious when they're suspended in the air over longer distances and over a longer time than droplets. Recent reports suggest 8 meters and 16 hours. Until recently, SARS-CoV-2 wasn't thought to be airborne, but outbreak reports related to indoor crowded spaces have suggested the possibility of aerosol transmission combined with droplet transmission, for example in choir practice, in restaurants or in fitness classes. The WHO guidance from March stated that the virus is transmitted primarily between people through droplets and contact. However, in the beginning of July, the WHO had to acknowledge evidence emerging of the airborne spread of the coronavirus after about 240 scientists from over 30 countries wrote an open letter urging them to update their guidance on how the respiratory disease between people passes. The letter concluded that the aerosol transmission has a significant role in the current outbreak, as some people who became infected were never closer than about 4 meters to a pre-symptomatic COVID-19 patient, and we know that even a cough only pushes large droplets about 2 meters away. Previous studies on the spread of Middle Eastern Respiratory Syndrome coronavirus have also demonstrated aerosol transmission. The signatories of the letter concluded by recommending 3 ways to mitigate the risk. One is ventilation, so maximise clean outdoor air, minimise recirculating air, particularly in public buildings. The second is airborne infection control, such as high efficiency air filtration and germicidal ultraviolet lights. And the third is to avoid overcrowding, particularly in public transport and public buildings, even if the building is empty at the time when you go in. Biological secretions, and therefore wastewater. SARS-CoV-2 has been detected in saliva, urine, sputum and faeces of patients. And what do we do with these things? What do we do with bodily wastes and used tissues? We put them down the toilet. One study has found viable SARS-CoV-2 in urine of 1 patient, and 3 studies have cultured SARS-CoV-2 infectious virions from stool specimens. So there's evidence supporting the possibility of a fecally mediated route of transmission that's accumulating. However, to date, there have been no published reports of transmission of infective SARS-CoV-2 through faeces or urine. There are studies conducted prior to the emergence of SARS-CoV-2, and they demonstrated that other coronaviruses are shed in faeces. For example, the MERS virus and the first SARS virus have both been detected in fecal samples from infected individuals. And in the case of SARS, that shares about 80% genetic homology with SARS-CoV-2, fecal shedding was noted in patients, and the RNA of the virus was noted in sewage water from hospitals treating those patients, although in that sewage no infectious virions were ever identified. If the possibility of fecal transmission, so either fecal to oral or fecal to fomite or fecal to aerosol route is established, it will impact on public health messaging and recommendations, including the guidelines on sewage exposure and residential care facilities and food preparation. But as yet, there are no published reports showing that.